Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are joined by Tim Cranton. Tim runs our year one of our bachelor's degree in remote paramedic practice. He just finished his MGH, his master's in global health with the college. Tim, welcome back to the program.
Thank you very much. It's been a little while, but hopefully I've got something interesting to talk about.
So tell us a bit about yourself and what's keeping you busy.
At this moment in time, I'm home. Not home. I haven't been home for long because I got delayed offshore. That's going to be kind of one of the things that I'll talk about in a bit. But I'm post MGH, having a little breather. Looking forward to starting the PhD, the doctorate in September. So a little bit more study. But I've just finished a trip offshore in the UK, and unfortunately, not only was I unable to get off, but so was a patient that turned up during that time, which turned out to be a little bit challenging to manage.
So tell us as much as you can about your patient and what was his main reason for showing up into your clinic.
So, I mean, kind of the backstory is that we were actually due a crew change, a week? So it was last Thursday before the weekend. We were due a crew change, and crew change morning, you check in really early. Everything has to be kind of packed up. And for me as the medic on offshore, I've got to make sure all my drugs have been checked. I've got to, make sure my handover and everything is done for the next medic that's coming on. But on that Wednesday evening, I saw a patient at around 9 p.m. in the evening, and he'd come to see me, and he was like complaining of toothache. Nothing major at that point in time, a mild toothache as he described it, kind of 1 or 2 on the pain scale, more of a dull ache than anything else. But he thought he'd come along and see me, asked me if I had some paracetamol, and take it from there. So as I said, I saw him. I had a look at the offending tooth, and to be honest, in terms of his teeth, whilst his dental hygiene and I would think it was overall pretty good, it was obvious that he had caries. So essentially he had signs of either old infection or decay in his teeth. And one particular tooth, which looked like it had quite a lot of cosmetic type construction done to it, he was saying that this tooth was sore. No swelling or anything to the gum, no pustules or anything like that, just describing it as a mild toothache. Baseline observations, all okay, feeling generally well in himself, but, got a toothache, can you do something for me, doc? So at that time, relatively simple because everything checked okay, no concerns in terms of infection. I gave him some paracetamol, and off he went to bed. And I didn't hear from him until, the following day. So the Friday, I normally start at around 6:30 in the morning. Now, the reason I didn't go off on the Thursday is because we had, this coming day, the Thursday, we had weather delays. So I saw the guy at about, I would say probably 8 or 9 o'clock in the morning. We already knew we had weather delays in a flight. And he basically said, my tooth's not getting any better, doc. The paracetamol kind of made it go away a bit, but, have you got anything stronger? So as we know, dental pain, arguably it's one of those ranks as one of the worst pains when you get bad tooth pain. And I'm saying, so in terms of severity, how does it feel? He says, well, yesterday, I described it as a 1, but I think this morning it's about a 3. Okay. He said, so I've already started on some ibuprofen because I had some in my washing bag, and I felt that took the edge off it a little bit, but I thought I'd come in and see you. Okay, no problem. So again, examined his tooth. Now, one of the ways of checking to see if there's any sign of infection is actually tapping the tooth, or putting some kind of pressure on it. So I did that. tooth tapping, putting pressure on the tooth. There's no signs of infection or inflammation that I can see on the gum itself. So there didn't appear to be anything local. He's just describing this as pain in that area. So because there's nothing really to look at, again, he's got no signs of temperature. All of his obs are good. He's generally fit and well in himself. What we don't want to do is just give people antibiotics. Of course, at that stage, that's kind of the expectation of a lot of people. And certainly for us, offshore, closed community, very much like a hospital, we've got to be responsible when it comes to antibiotic stewardship. So despite what Dr. Google might say, it's not a question of just giving someone antibiotics for a toothache. It's a good idea to obviously be able to manage the pain and discomfort. And he'd also said to me that he thinks a part of his tooth is now missing. So further inspection basically showed that a part of the filling of the offending tooth did appear to come away. So at that point, it's like, okay, it seems to be getting better. Most likely, it's due to the fact that you've not got adequate covering of the root of the nerve. So we will attempt to fill it, or fill the gap where the tooth appears to be damaged, and see if this offers, any respite. And he was saying that, he could feel temperature difference, so he would get pain if he had anything cold in his mouth. So we went down the route of giving the tooth a good toilet. So mouthwash and then irrigation. Now, I don't have, lots of weird and wonderful dental equipment. So when it comes to irrigation, very much like kind of wound irrigation in a remote healthcare setting, a needle and a 20 ml syringe, and just hosing the tooth as much as I could to try and make sure around the gum line and around this kind of hole itself, there's no debris, nothing there that could harbor any infection. And then we have Cavit. So Cavit is a temporary filling material that we can use, and it works, but it only really works well if there's something to hold on to, and it's kind of difficult to describe unless you've got pictures, which I've taken, and I'll have to share those with you at some point. But if there's nothing for it to kind of adhere to, it will last a few hours, but then it tends to fall out. So actually getting any kind of filling into this tooth was actually quite challenging. So we dressed it, albeit a temporary dressing, and started the patient on ibuprofen. But he was taking around 200 milligrams 300 times a day, which was obviously not having any effect. So with him being a larger gentleman, we started him on 800 3 times a day and added cocodamol, so paracetamol and codeine. Codeine's usually very good in terms of pain for toothache pain. To that, so 1 gram of paracetamol, and it will be 8 milligrams, 16 milligrams then of codeine, plus the 800 milligrams of ibuprofen 3 times a day, and then obviously come back and see me if the symptoms worsen. So off the patient goes again, and we have another day then, a full day of weather delays, particularly fog. So most certainly offshore this time of year with the warmer weather, we get a lot of fog. So Thursday we were all day, no flight. I've got a patient potentially that might go in. He's okay at this moment in time, but we'll see how he goes. The Friday flight unfortunately didn't go either. Similar reasons: weather in Aberdeen, weather in Sunborough, weather offshore, no alternates. So when you've got fog, triggered lightning, you can't fly anywhere else but your destination. Helicopters don't like to take off. So we move into Saturday, and the patient seemed relatively stable during the course of the day. I saw him in the kind of early evening time, and he said, yeah, I'm feeling, kind of better. Pain is definitely under more control now with the cocodamol and the ibuprofen. I should be okay. Thank you very much. We get to Saturday, early hours of the morning, so around 6 o'clock. I get a call in my cabin. Doc, I haven't been able to sleep all night. This tooth is driving me crazy. I'm going up the wall. Please, 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 can you do something about it? Right. Okay, no problem. I'm right next door to my sick bay. I will be there in 2 minutes. I'll put my, a shirt and tracksuit bottoms on, and I'll be there. And the difference in that patient within the space of, a relatively short hour period, since I saw him, so 12 hours, he's red-faced. He's in obvious distress. You can see that he's tired. He's holding on to the side of his head saying, please do something about it. So my immediate reaction is, obviously, I want to make sure everything else is okay. I need to do good baseline observations, because if it is an infection, the last thing I want, especially in the environment that I'm in, is it becomes systemic, knowing as well that I've always got topside to refer to. So there's a certain level of medications that I can give a patient without referring to topside. So I can give him the cocodamol, I can give him the ibuprofen, but if I'm considering antibiotics, then I need to speak to topside at that point. So obviously I had a look at the tooth again. This time he's got pain on tapping. He's got pain, quite a lot of pain when I'm putting any kind of pressure on the gum area and on the tooth itself. Tooth is not loose. The tooth is stable. He has a mild temperature. His blood pressure is elevated, and he's obviously, very agitated. So now I've got a poorly patient who's not very happy. And after checking with the radio operator, we have further flight delays, flights on hold. So I explain, well, I potentially got a patient here that I might need to get in. And when you get the response from the radio operator, well, good luck with that. Then obviously that, it doesn't look very good. So one of the things we have most certainly offshore in the UK is we have topside medical cover. I've already given my patient, as much as I can possibly give him in terms of the analgesia and anti-inflammatories. So I call our topside medical service and I explain that I've got this patient, but everything I'm doing so far just doesn't seem to want to respond. I don't want to give him antibiotics yet, but I have them, if I need to give them, but I want to have a discussion with topside first. And this is kind of, I guess, atypical of the whole offshore thing and how it works in terms of having that service, having telemedicine there to back you up. When you kind of done everything you think you can do, and it starts to get out with your scope of practice. I'm not a dentist. I have, where are we, page 136 and 137 of our field guide that I can obviously refer to, and a few other books that I might have. But essentially, they're all telling me, extraction. We don't have the equipment to extract teeth. And at any other time, I would have sent him in probably 24 hours earlier on a routine crew change and go straight to the dentist. But obviously, we weren't able to do that. So I explained everything to topside, and I already have a management plan. And the expectation when you call topside is they don't want you going backwards and forwards to the patient, asking questions, asking if they've got any previous medical history, anything that's significant, any other medications that they might be on, any of the observations. The doctors want all of that information in Medbase prior to making the call, so they can then see everything live. Obviously, I've took pictures, so you post those pictures to Medbase as well, so the doctor is also able to see them at the same time. So anyway, I spoke to the topside doctor. At this moment in time, I've actually switched my patient from cocodamol and ibuprofen to tramadol, so Meptid, and naproxen. And in terms of the pain management, that had much better effect than the cocodamol and the ibuprofen. So having him on the tramadol and the naproxen definitely seemed to manage the pain after roundabouts probably about an hour or so. I spoke to topside and he's like, yeah, I think we need to get the guy on antibiotics. What do you have? So obviously we now have to go through the course of my inventory, what I've got available. And the thing is, with tooth infection, there's any number of things that can cause a tooth infection. but we usually go with something that's kind of broad spectrum. So amoxicillin was the drug of choice, and that's the amount we put him on. But again, when you've got a patient with infection, obviously you want to be able to get those antibiotics on board. So 500 milligrams of amoxicillin 2 to 3 times a day would be the standard dose. But on the direction of the doctor, based on the amount of time that essentially the infection had to incubate, was to double dose the first dose, so that would be a gram, and then to give the 500 the 3 times a day thereafter. So thankfully, now that I've got the patient managed pain-wise, I've had permission to start him on antibiotics plus additional oral hygiene. So again, we're making sure that everything stays clean. We're using Corsadil, so a chlorhexidine mouthwash. We're doing that 3-4 times a day, and the patient is coming essentially backwards and forwards to see me. I have a ward facility, but it's very limited, and it's more comfortable for the patient, or for me to manage the patient in his cabin, and then me visit him various times of the day, or arrange for appointments for him to come to see me. Obviously, the fact that the patient's not sleeping, he's in a considerable amount of pain, then I'm managing in his cabin up until that point. So this was the Saturday. So we're 3 days of no flying. Unfortunately, flying was cancelled. So some people might ask, well, why couldn't you just got search and rescue out and fly the patient in that way? So unfortunately for search and rescue, they're subject to the same flying conditions, obviously, as our contract helicopter. And one of the biggest issues is because of the fog, it's going to be very difficult to winch somebody onto your helideck when you can't see your helideck, because the cloud base is so low and the fog is that thick, as well as the proximity of a live flare stack. So because we're producing oil and gas, we are venting gas that's essentially being burned off. So the last thing a helicopter obviously wants to do is strike something like that is in relatively close proximity to the helideck. So in terms of landing, no. In terms of winching somebody on board, no. So also you've got to consider alternates. Now for us, we're 350 miles north of Aberdeen, so several hundred miles to fly anyway. So fuel is obviously an issue. Normally our aircraft will fly from Aberdeen to Sunborough, refuel, and then we'll fly from Sunborough to our location. So it's normally around an hour and a half up to 2 hours, depending on the weather conditions, especially with a headwind. So unfortunately, on the Saturday, flying was ruled out again. This went through into the Sunday. So my patient, thankfully, over the next 24 hours, has settled quite considerably. The antibiotics appear to have kicked in, which I say the antibiotics have kicked in. He's on a combination of tramadol, naproxen, and now amoxicillin. One of those medications must be working. And the fact that we've got him on antibiotics, had him on antibiotics now for 24 hours, with the patient much settled, means you can kind of breathe a sigh of relief. Observations obviously now a lot more stable in terms of his pain scale. Instead of it literally being a 9 or 10, the worst he's ever felt, it's now back down to a 3 and a 2. He's definitely able to manage it, and he's also able to sleep. And there's nothing worse, especially when you're in pain, of not being able to sleep as well. So thankfully by Sunday we've got a stable patient. Sunday no fly. Monday no fly. Tuesday was actually the next day that we were able to get a helicopter to the installation, and it was arranged on that Tuesday morning that our patient would go in. Now we don't have, whilst we have a Medivac, we don't have Dentivac. It comes under a medical emergency. But hospitals obviously don't like taking dental patients. That's for a dental surgeon. And if anybody ever knows anything about the UK, getting an appointment at a dentist in the UK can be quite challenging. But thankfully, because we'd made that call to a dentist over the course of the weekend, there was a dental surgery appointment literally waiting for us for when the patient got on shore. So we were managed to get on shore on around lunchtime, 1 o'clock in the afternoon. The patient was able to undergo dental surgery later on that afternoon. He sent me a message the following morning to say, thank you very much. The pain's gone. It's like I never had a problem. And I'm also now minus one tooth. It seems like a relatively simple thing to have to deal with. But when you've got a patient that's in obvious distress, you want to be able to put them in a place, i.e. a dentist, to be able to fix them. But when you can't get the patient out of your remote location, it really brings it home in terms of, one, remote healthcare. What have I got and how am I going to manage this? And when am I going to be able to get the person to definitive care, and how am I going to get them there? And a lot of the time we're told, yeah, it'll be okay because you'll just get search and rescue out. But when search and rescue say, I'm sorry, we can't land or we can't winch somebody down onto your installation, it obviously does happen. And you have to be able to manage it yourself. Thankfully, we had the things we needed in the cupboard. And I had a good topside physician who was able to talk me through, one, the process of managing the tooth itself in terms of making sure it was clean, and two, obviously the pharmacology, talking me through that, picking the right pharmacology for the patient, and then waiting for it to work. So yeah, it doesn't seem much, but actually it could have been a lot worse. If you think about the potential for sepsis, the potential for infections like pericarditis or meningitis. Thankfully, that didn't happen, but the potential is there that it could. And this wasn't injury, it was illness. So yeah, a little bit of a challenging weekend, but I've had a little bit of time off to reflect, and hopefully people can learn from that. I definitely need to write a reflective practice paper on it.
Indeed. And I can hear Berger Langana listening to this podcast and just jumping at the chance to get you to extract a tooth. So one question I had was, what about lidocaine with epi? Why couldn't you do it block?
Do you know what? We don't have lidocaine with epi.
How about just straight lido?
We don't have injectable lidocaine.
You have cardiac lidocaine.
We have cardiac lidocaine. So you're taking the words out of my head. So yeah, we have cardiac lidocaine. There's just an aversion. Essentially, when I called, I said, God forbid I have to get a Leatherman, which I have, to pull this tooth out. It's like, no, you need to leave it. You need to leave it. Let's go down this route first. And the antibiotics was, and obviously the pain management, the anti-inflammatories was the treatment of choice, and that's what I was directed to do at the time. I think if we'd have got to a point where we were not managing the pain, and the antibiotics had been given 24, 48 hours to work, and that was not working, I think that would have been the only route I think that we could have gone down. It's going to mean a reconsideration for maybe having dental tools, certainly having some dental needles, having some lidocaine that we can use. We do dentistry as part of basic dentistry as part of our Offshore Medics course, but it was almost like I wasn't allowed to put it into practice. But in the same time, we just don't have things really. The only thing I have to manage teeth is Cavit, which I talked about, temporary filling, and a traveler's dental kit. That's really the limitations of what we hold in our inventory.
Did you sit through Berger Langana's workshop at our conference last January?
I definitely did. Brilliant, fantastic.
Yeah.
We learned so much from Berger. I've known him obviously throughout my kind of offshore career. From kind of the military side of things, and then moving into offshore medicine. So he's definitely been a voice for remote healthcare for a long, long time. And I can, I'm trying to recount all of the things he'd said to me about how to manage this. The worst case scenario, like I said, would be extraction of this tooth. The frustrating part of it is not having the things that I think I would need to be able to do that. We used to have things like that on our inventories, but a lot of stuff has been taken out. Worst case scenario, I would be speaking to a dentist over topside and getting them to talk me through pulling it out, I think.
Well, a dental elevator is what, 20 quid. So
Yeah.
it's not like a huge amount of costing to have the right amount of equipment, and lidocaine's cheap.
Yeah, I think it's the issue is in terms of the companies and stuff. It's obviously it's training, experience. One of the things we don't do, which again I would really like to do, is actually spend some time in a dental surgery with a dentist. We do, hospital placements, obviously. We do clinical placements and the like, but we don't go near dentistry other than in the classroom, which again proves why Bajor's workshop in Malta is of so much value.
And looking at our bachelor's degree program, we don't cover it at all in year one. We only
No.
do it during our TTEMs in year two. Are we remiss?
Well, yeah, in hindsight, maybe we are. I would really like to see, again, this whole hindsight thing, I would really like to see 24, 48 hours spent with a dental surgeon, spent in a dental surgery. I don't know if that's possible at any of our placement sites like Kilimanjaro. Or
it is
or,
very much so. Both
I think
Cabosho and KCMC have Cabosho has a great dental setup.
Maybe that's an addition we need to put into our workbooks. I would definitely like to see it. I felt frustrated because one, I couldn't maybe kind of get in there and do what I thought really needed to be done with this tooth. But at the same time, obviously, I need to follow medical advice. But yeah, and not having the kind of tools makes it kind of frustrating. But no, it's definitely something that that and prolonged field care as a subject. It's not just the dental side of things. Actually sitting on patients and having to manage them, and especially with prolonged field care, you have to wait. You have to wait and see if your interventions are working. You have to monitor your patient for extended periods of time. But at the same time, you've got to make them comfortable. Pain management, again, is so important. Giving somebody a couple of paracetamol, some ibuprofen is just not enough sometimes. The next stop for me, if the tramadol plus paracetamol plus naproxen was not working, would have been something intravenous.
IV paracetamol would be fantastic, but
Yep.
it's not going to last long enough, is it?
And this is it, and that's the whole thing: is repetitive doses as well. Do I actually have enough medicines in stock to be able to to manage this? And as it is, I actually depleted my stock of naproxen and pretty much half of my stock of ibuprofen, because we don't carry huge amounts of stock. Tramadol, we have 112 tablets in stock of tramadol, and that can get used up quite quickly in a patient that's in a fair amount of pain. So yeah.
Is there no discussion of prolonged care in the Offshore Medics course? When I was teaching it 10, 15 years ago, there was nothing on it. But is there anything new, or is there any
changed.
concept?
It's not. Well, so I mean, I don't want to name names, but I would definitely say that the two providers that my company uses are arguably the top two in the UK, and you spend time on the short type emergencies. You do ACLS, you do PHTLS, but it's all stuff that can be dealt with within the hour. And if you do any scenario-based training, it tends to only last for 10 or 15 minutes. Whereas we know, because obviously we're doing PFC exercises when we're doing AEC or when we're doing our BSc program, that you need to do extended exercises so that students get a better concept. I think if you're a nursing medic, or a medic that comes from a nursing background, you probably have a better understanding of prolonged care than the paramedics do. And I definitely think it's something that needs review in terms of the offshore medic training. I highlighted it when I was writing my thesis for my master's. And it's something that I want to be able to carry further and look into in more depth, certainly for the PhD that's coming up. And I'd like to think I could be instrumental in maybe getting the program updated because there's definitely updates that need to be given to the program.
Yeah, the HSE isn't really interested in updating, are they?
Yeah, I mean, there's no, in terms of the HSE, they are a governing body that manages health, safety, and environmental more than anything else. I've never spoken to a doctor from HSE itself. I've only ever spoken to kind of inspectors that are looking at safety related issues. I've never seen anyone or spoken to anyone to talk directly about health related issues. You've got the United Kingdom Offshore Operators Association. They have a medical board, but again, they don't really issue any directives. You have to be able to manage cardiac arrests. You have to be able to do CPR, ACLS. You have to be able to manage a trauma patient, and you have to be able to manage minor illness and injuries. But it doesn't specify how long you have to hold them for, and what to do when you do. And when we look at prolonged field care, when we do the austere emergency care course, we do an exercise where we're on patients for several hours, and we're having to consider a whole lot more than just the primary insult. There are other things that need to be considered. I did a presentation actually at the Shell Medics Forum last year, specifically on prolonged field care, because like I said, I feel that there's a gap, and it raised a few eyebrows. And the medics, when I say medics, the clinical oversight that were in the room didn't kind of say too much, because I think there's that realization. But at the same time, what the offshore industry tends to do is it looks at the cost versus risk and what are the chances of it actually happening. So when they look at their risk analysis and say, well, it's highly unlikely that this is going to happen, so we don't really need to spend too much time on it, so we won't until it happens. So yeah, it's definitely a subject that I think needs further attention, needs more focus. And PHTLS and ACLS, you can do that all in 1 week. We have 2 weeks of training. You could spend the second week on just PFC type or clinic-based scenarios, which we just don't do.
I was at a conference a number of years ago and ran into one of the big wigs of the oil industry, medical side of it. And I was trying to talk to them about ultrasound. They just weren't interested because they thought that you guys wouldn't be able to learn the ultrasound. So they're not going to spend money on teaching you guys something you can't learn. And it made me very cross.
Yes.
And they're very wrong.
Yes. And it's something that we don't have either. I mean, first off, obviously come from a paramedic background. I'm state registered with the HCPC in the UK, so I know what I would normally carry with me in terms of, an ambulance. And there's some basic things. Whilst an ambulance, there's no expectation for a paramedic to do anything dental wise other than maybe an avulsed tooth that's bleeding. There's a certain level of equipment that you have and you would expect to have as a paramedic. Sometimes you can go offshore, certainly in the UK, and it's like, taking a step back in a bit of a time warp. You just don't have access to the things that you think you should have. And I do think that the offshore industry in the UK, it needs a bit of a revamp. We really need to look at what we have in terms of inventory, but at the same time, we really need to look at the medics. And I think we need to focus on the medics more and offer more in terms of, training providers. But at the same time, as organizations, companies, out with those refresher courses that you do as a medic once every 3 years, there should be something at least annually. Thankfully at Shell, we have a medics forum, and we do spend 2 days. We have a whole clinical day. We will have a day where we have discussions, and actually time is offered to the medics in the room, to the attendees, to make their own presentations. So actually being given the opportunity to bring my concerns about prolonged care to light is also really good. So in some respects, Shell are proactive in it, but at the same time, there's always going to be some cash cost implications. And we also focus on other roles as well. We're not just the medics; we're the occupational health focal point. We're also doing other things, and their biggest concern is getting the oil out of the ground. If it's anything that the medic can't deal with now, we'll just fly a helicopter out. And I think I've demonstrated that that's not always possible.
Tim, do you think there's a need for Quorum to create our own HSE Offshore Medics course and run it the correct way?
100%. I would very much like to be instrumental in a program like that, and I don't think just myself as well. It's kind of unfair. We need to bring in some more offshore medics into the room. Maybe that's another podcast we can have, and we can get a bunch of offshore medics and we can see what their views are. But I think because we get it, because we are already medics working in remote healthcare, we can see the gaps. I don't, no disrespect. I understand that some guys, they just want to come do the job and go home. But, you as a medic, you have a responsibility, not just to your patients, but to yourself. You've got to be able to keep yourself up to date. And it will happen at some point. You will get that patient when you least expect it, and you're going to have to dig deep. But at the same time, you'll have no choice but to sit on them. And you're the only person that's going to be able to manage that patient. So the more training, the more experience, the more knowledge you have, it has to be a good thing. Not just for you, but for your patients, for the installation, for the organization that you're working for. I was going to say, you were saying about courses. I would love to see us have a dental course. I think that would get some good attendees.
Well, one of our faculty does this for a living. Berger Langdana teaches wilderness dentistry.
Yeah, I think Berger, if we could get him to do a course, I mean, I'm not sure how long the course would be, 2-3 days. I think there's so much we could cover. Even the workshop again that we did in Malta for the Medicine in the Mediterranean conference, which obviously we're going to be having again in 2026. So hopefully Berger will be there doing his same workshop, which I would encourage people to attend.
Well, Tim, my final question for you is this. What advice do you have for anyone who wants a job like yours, working as an offshore medic?
Become a plumber. No, I don't mean that. You obviously need to go to school. So that means you're going to be time served as a medic within the armed services. So tend to look at this from a UK-centric perspective. But ex-military, Navy, Air Force medic. You can also now do the offshore medics course coming in as a paramedic. You couldn't before, but that's been open now for a couple of years. And I also understand that after having completed our 3-year BSc program, we've already got, I think, at least one guy that's enrolled in his offshore medics course. So there's access to the offshore medics course through our BSc, and that's obviously open for international students. But be mindful that the HSE Offshore Medics course is a UK course at this moment in time. But yeah, go and do your basic foundation training, so your nursing training or your paramedic training. Get yourself on your Offshore Medics course, which you can do with a number of training providers that are currently based in the UK. You're also going to need your basic offshore and firefighting and first aid training. You will need the MIST training, so minimum industry standard training, which basically takes you through all of the health, safety, and environmental type training. I think that's a course now that you can do online. And you will need a medical to work in the UK oil and gas industry if you so wish to. But again, that offshore medics ticket, that does open doors internationally as well, because it is so well recognized worldwide. I know there are contracting companies in the Middle East doing things like private security, etc. One of the things they've asked for is UK offshore medic certification. You're not going offshore, but because they see it as a good basic foundation, to get on that course, obviously you have to have prerequisites. So they know that if they've got a person with an offshore medic course, they're already coming from a medical background, they've got their PHTLS, they've got their ACLS. so they're not having to worry about them going on other courses. So yeah, that's what you're going to have to do. It's not going to land on your doorstep. You can't literally sit at home and wait for a phone call. Essentially what I did a little bit back in the day now, but is I printed out a ton of CVs, resumes. I got on a train. I went to Aberdeen. I went around every offshore company that was pretty much in the phone book at the time. Gave them a copy of my resume. Said I can start work as an offshore medic tomorrow. Please give me a job. You've got to be proactive. You've got to network. Medicine in the Mediterranean, that's obviously a good opportunity for networking, because there's going to be a bunch of us that work remotely as well as offshore. So you've got to get on social media, various social media outlets out there that you can get access to, and you can get access to other people as well. So Google will definitely come in handy when it comes to doing a little bit of research, and hopefully that will get people started. I don't mind if people give me a shout. They can get in touch with me through social media as well, and I'll point them in the right direction.
Thanks for the vignette of dealing with a prolonged casualty, Tim. It was excellent to have you back on as a guest of the podcast, and we look forward to seeing what you can do in the future.
Thank you very much. Much appreciated for the time.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.